So it is my pleasure to introduce, I think, the final speaker for this afternoon, and then there's a reception, and then there will be one final session later this evening from 7 to 9. But I really wanted to tell you all about Kathy Reynolds, who many of you may know, and who I've had the pleasure of meeting on several occasions now. And Kathy's going to talk about something near and dear to my heart, which is kind of the introduction to effective behavioral health service delivery in primary care. And I wanted to tell you a little bit about Kathy. So she's been in the business of mental health and substance abuse for over 30 years. She currently is serving as the director of the SAMHSA and HRSA Center for Integrated Health Solutions for another couple of months. And starting in July, she will actually be moving from that position, but still staying with the National Council, but going back to kind of what's near and dear to her heart, which is really leading their efforts in launching and delivery of all of their consulting, technical assistance, and workforce development programs for behavioral health and primary care integration. So she's been getting lots of requests to come out and help people do this, and do this well. She also is serving as the Vice President for Health Integration and Wellness for the National Council currently. And prior to moving to this position, she was the director of the Washtenaw Community Health Organization in Michigan, which was a nationally recognized organization in the integration of behavioral health and primary care services. And it included a community mental health services program, a substance abuse coordinating agency, and primary health care capitation dollars for Medicaid and indigent consumers. So she really has done this and has a lot to tell us. She graduated from the University of Michigan School of Social Work, and I won't say when. And she has presented at numerous conferences, conventions on the topic of integrated health, has a manual called Raising the Bar and Moving Toward the Integration of Healthcare and Manual for Providers that is in its second edition and has been used widely to implement integration between the public behavioral health system and primary care providers. And something that not a lot of people know, but that I thought would be of interest, is that both her parents are teachers, and so she was actually taught by both her parents in the 7th and 8th grade, which was also a very good learning experience and taught her probably a lot of patience and endurance that has proved to be useful probably in many of her positions. So, no further ado, Kathy Reynolds.
Thank you very much. It's good to be back here with you. You may remember I joined you out in Ocean City last May to talk about some of this work. And yeah, it was always interesting as a teenager. You really want to go to class and see your mom and dad standing up there teaching you. So did learn a lot of things doing that though, so it's great to be here. And just so you know, I did review the presentation I did last year so that I don't repeat myself. And even more importantly, I'm doing a couple more things here. So I've made, if you follow me through your conference, each presentation is different and builds on a little bit more of what we're doing related to healthcare. So wanted to start with this cartoon, which says, we're ready to begin the next phase of keeping things exactly the way they are. So you all have been there, done that, huh? As someone who's been in the mental health and substance abuse field for a very long time, one of the things that I'm very aware of is that sometimes when change that we're looking at comes towards us, our instinct is to pull our arms and legs in and our head into our shell and become a turtle and wait till it passes over, and then to come back out after it's all done and said, see, I really didn't have to do that. But I'm here today and throughout your conference to talk to you about the fact that this time around, we think if behavioral health organizations do that, when you stick your head and neck back out, there may be no role for us because of some of the changes that are being done, that people will have gone on without us and just sort of said, well, I didn't think they wanted to partner, so I went ahead and created my own system. And that's what we're starting to hear a little bit, is that we can be pistols to partner with when folks try to do that. And I'll talk a little bit about some of the policy changes where folks actually can move forward without us. And so I'm here today to try and move all of us forward in terms of our strong need to be active in these health homes that are developing across the country and in Maryland and across the states to do that. I've been an advocate, a proponent of this since 1995 when we started our first integration project in Washtenaw County, Michigan. At that time, we didn't know that we were creating a patient-centered healthcare home. We just knew that healthcare was a huge issue for the folks that we saw with mental health and/or substance abuse problems or both, and we knew we needed to do something about it. So if you go to Washtenaw County, we had 7 health clinics that we moved mental health and substance abuse services into, and we brought primary care services into our mental health center at the time that we were providing services. So we were doing this collaborative care, patient-centered healthcare home, and I use that term specifically because if you look at the literature on medical homes, one of the things that concerns me is they often forget to include mental health and substance abuse treatment in the medical home. So through the National Council and through the work that I do, you'll always hear me say healthcare home. I see it as the same thing as a medical home, but it just has people continue to remember that they can't be successful in healthcare without those of us who have specialized in mental health and addictions treatment over the years. So if we're really going to bend the cost curve, we have to be present and we have to be in these health homes as they develop. So I want to talk with you, you may know this, but the states do have access now to 2 things. They do have access to a $500,000 planning grant. I do not believe that Maryland has taken advantage of this. When I bring up my slide, Maryland is not on it, but there's a $500,000 sitting at the Center for Medicaid and Medicaid Services for all states across the country to apply for a planning grant to do health homes. Now you may not need that because some of you have shared the documents. You've got an incredible amount of planning already going on. You've got a lot of documents in your state director's hands and things moving, but there is the opportunity for this planning grant. Takes about a 2-3 page application. The money doesn't expire once you get it. You can use it over a period of years if you need it to plan for health homes, but something that's out there. And I need to tell you that even states who are suing over the Affordable Care Act have accepted planning grants from the Affordable Care Act to plan for health homes. So don't feel like there's a conflict of interest or anything in that. And even if there is, you know, sometimes we just think 2 things that are contrary and move forward. So, but there is that available. And then the second thing is through the Affordable Care Act under Section 2703, there is the opportunity for states to go for a state plan amendment to their Medicaid programs, which would fund these 6 services which currently often aren't funded in the state. And so you see there the care management, and I heard Laura's presentation, and you know we're doing a special training on moving in from case management to care management. It's because the new waivers pay for care management. And we have a ready workforce that can do this, and we just need to get it prepared as we move forward with the new health homes. Care coordination and health promotion, how long have we waited for funding for that? Transitional care. Oftentimes, you know, folks just leave the hospital and they don't have anywhere else to go. Now there's a funding stream for that. Patient and family support. Sorry that I'm having to turn my head, but even with my LASIK surgery, I can't see the computer to see what this says. And then also health IT. You know, you can use some of this in using health IT to move forward. So if the state decides to pursue this after you do a lot of the changes that you're already doing on your behavioral health integration and then integrating behavioral health with primary care, you can get 8/4 of a 90-10 federal match for these services moving forward. So really nice opportunity from the federal government to fund what they're talking about. So it's not an unfunded mandate that we're talking about here today. I need to say this. My colleague and I, Joan King, and I were training in Philadelphia earlier this week, and we were talking about health homes, had done the home warning, and somebody came up and said, so this is a residential facility, right? We're like, okay. Now you came late when we talked about it not being a residential facility, or it's not registering. So a health home is not a spa that you go to and you get all tuned up and then you come back out and take care of life. It is a clinic somewhere. It can be at a primary care provider's office, but the Affordable Care Act also allows it to be at a mental health center or at a substance abuse specialty addictions provider's site. So it's not limited to being in primary care. So it can be in our sites, but it's also not a residential facility. It's a place where somebody is looking at your whole body. You know, we're stopping that, you know, kind of cutting the head off and setting it over here and putting the body over here, and then the poor neck is left to stretch to try to bring things together. So we're putting the neck back on the body and saying, look, somebody needs to coordinate all of the care that this person needs, not just the care they need for their head or the care they need for their body. The other thing that it's not, at least in everything that I've seen, and I've been very excited about this, is it's not what we went through the last time, which was almost the primary care provider as a gatekeeper, and they were reimbursed for keeping people out of specialty care. You know, that was one of the things, is they got the money, and then if they didn't spend it, they were able to keep it for profit. The incentives in the accountable care organizations and those things seem to be aligned to pay for the needed prevention services and the needed care that the folks we serve in our system need. So it's a fundamentally different approach to payment and how things are going to happen. So I'm pretty excited about it. I was excited enough about it that the National Council was able to bring me out of retirement to work for them because of the opportunities that we have going forward. And I do need to make just one correction to my introduction. I was so interested in getting back out on the ground and working with folks. I loved the opportunity that I had to run the Samsa Hursa Center for Integrated Health Solutions, but I retired specifically to get back out on the ground and to work on the ground with providers and folks in doing integration. So I asked if I could please resign from that position, and Linda and Jeannie allowed me to do that, and Laura Galbraith, who you just heard from, is the interim director. So if any of you are looking for a job, that position is open, and you can apply for that. So I actually am now simply doing the work of leading the integrated consulting work for the National Council, and really excited about that and enjoy being out working with providers and consumers on this. So what is the healthcare home? There are these 7 aspects that we're going to talk about around the healthcare home. Access, superb access to care. We talked a little bit about this a year ago when I was here. We're going to frame it in terms of the healthcare home. Patient engagement, which we are experts at, hopefully, in terms of the folks that we've worked with over the years. Clinical information systems, where we are very far behind the curve, hugely far behind the curve. Care coordination, which I think, again, we are experts in out of the behavioral health centers so that we can bring that to there. Team care, again, a strength for us. Providing patients feedback, we're getting better at that. We still have some issues with that. And then publicly available information. I'm going to talk a little bit about each of these as we go forward. Sorry?
When you said we are behind the curve, you mean nationally?
I'm sorry, I still, even though I've always worked with an integrated system, when I say we, I say the behavioral health community. The mental health and substance abuse community is, when I say we, I still identify primarily with that, even though I worked in an integrated system for 15 years now. My true heart is with mental health and substance abuse care. And I'm learning the primary care business and working with that. But when I say we, I'm talking about those of us who, over the course of our careers, have spent the bulk of our time working in mental health and substance abuse. So when I said we were behind in clinical information systems, I think one of the last surveys I saw, only 17% of substance abuse agencies are computerized, and it's only slightly more, like 20-25% of the mental health agencies are computerized. So it's going to be critical that we get those numbers up. Now, part of that is we didn't get any money in the Health IT Act, but we have legislation pending that was introduced by Senator Stabenow and some other folks to rectify that situation. When I was here last year, we had this conversation. I'm hoping more folks raise their hand this time. How many of you now provide same-day or next-day access to care in your treatment programs? Okay, a few more hands, there we go. We talked about this last year, about this being critical. One of the components of being a part of a health home whether you're on site or you're in a referral relationship or you're thinking that you're going to partner with one of the accountable care organizations that have been funded, is that you have to be providing same day or next day access to care. Now, that's not same day or next day access to an intake person who will do all the paperwork. You know, it's not same day or next day access to an intake group. That's same day or next day access to actual treatment. Now, for substance abuse, that's going to be and I'm not substance abuse, for residential, whether it's mental health or substance abuse residential care, you know, some of that's obviously not going to be able to happen. There's no way we're going to have enough beds to have treatment on demand for residential settings and some of the higher end cares. But for outpatient, intensive outpatient, some of those things that we have, there's going to be an expectation that we can have the same day or next day appointments, and because we're part of the healthcare system now. And if you called your doctor and said you had a sore throat, and folks say this isn't quite a realistic example, but I actually think it is. If you called and said you had a sore throat and the doctor said, well, we have an intake group on Monday, come on in and we'll have somebody you know, see if you can pay for it and if you're motivated to take your medications, and if you didn't, you know, those sorts of things. And so that's a bit of an extreme example. But what we're talking about is responding more to consumer and patient and customer requests and being able to have same-day access to treatment. Comments on that? Any of you who are doing same-day access willing to talk a little bit about how it impacts your system? Because most folks have found that it increases engagement, it increases folks getting into treatment, and it actually increases retention when you do same-day access and respond when folks are ready. Dr. Olson?
Yeah, so I work at the Institutes for Behavioral Resources, the Reach Health Services Clinic in Baltimore, which is a methadone maintenance program. But there we have we had to tweak a little bit kind of the scheduling, because I see both, and we have so I work there 2 days a week. We have a full-time nurse practitioner, and she and I kind of worked out the schedule with our intake coordinator so that there's an intake, there's a 1 hour long intake assessment, or I guess assessment appointment every day from 9 to 10. And then the 2 mornings a week that I'm there, I then have my initial history and physical appointment from 10 to 11. And then the nurses, we worked out so that they do a little bit of a medical orientation kind of to the methadone treatment right after. So I walk the person from my office once I'm finished to next door to the nurse, so that she can then, he can take and kind of do a relatively brief and then get the person dosed. And what we found is that people who call, because we have the system basically Monday through Friday, that we can then actually get people in. If they call today, they can come in tomorrow, and our intake coordinator is flexible enough so that if she has people scheduled for the morning, she'll schedule them in the afternoon. And then we worked out so that we have about 10, we looked at kind of our typical admission rate and figured out that we needed about 10 appointments, both the intakes as well as the H&Ps, over the course of the week to actually kind of meet our typical average rate. And then sometimes we have to adjust it, you know, depending on kind of if there are more people who are asking for our services.
Excellent. Listen to all the things she said she had to change about the way they did business. You know, and some data-based work around how many appointments they would need and how even you make adjustments on the fly to be able to accommodate demand moving forward. Absolutely. Anyone else want to share how they've done this? Go ahead, please.
I actually have a question. I work for an outpatient substance abuse provider, and we've made some changes into our orientation and intake process in order to improve our access to care. This is more of a question because it seems like the example you gave is for primary care, where people are coming for basically 1, 2, maybe 3 appointments, but in substance abuse they're coming for many months, where it's hours at a time. So I guess I wonder, how do we get them to treatment if we have people that are continually coming back every week? So it's not just a short-term fix because they're
This is a huge issue, and Lady and I will be up here tomorrow, and we'll talk a little bit about some of these issues. Does anybody know the modal number of outpatient sessions for behavioral health consumers across the country? Modal being the most frequent number of sessions someone attends? 1. Okay. So the modal number of outpatient sessions that are usually attended by someone in mental health or substance abuse treatment is 1, and the mean is 3. So one of the things we need to be thinking about is how we move forward in that. So I'm not saying that you don't have people who are returning and those sorts of things, but one of the things that we need to be working on is our models of care and how we provide them and the expectations that we have for folks. So we need to be thinking through how we handle that. Now, the other issue that we'll be talking about is you have to have a balance of your clinicians. You were talking about methadone in an outpatient program. You know, we usually have this whole group of intake folks and all of that. You want to try to align your intake folks so that they do the intake. They also keep the patient as it goes through, as they go through after they've done the intake. And so you do a balance of time between working intake and taking in new folks, and then your ongoing scheduled clinical appointments. The other piece, and this is the one that is really challenging, particularly for clinicians when we talk about making this change. In order for this open access to work, you have to take the clinician's scheduling of their own appointments away from them. Yeah, listen to the response to that. But the only way, and I don't know if those of you who have done it, some are nodding that had their hands up about open access. One of the things that we've found in doing this work is that clinicians and are good-hearted, and I was a clinician, so I'm not talking out of school here, but clinicians often don't schedule in the same way that a central scheduling mechanism would work. And so there needs to be some additional systems changes in having clinicians not schedule their own appointments, some double scheduling, making people available on the fly to do this, but there's probably half a dozen key things you have to do to move to open access. Don't know if those of you who did it did the NIATEX process. They have a project out of NIATEX that shows you how to do this in substance abuse, all types of substance abuse treatment. You've done the NIATEX work. Do you want to talk about that?
Yeah, we just finished our first go-around and participated in the NIATEX, where we did the percent of increases for access in an OMT program and reduced it during a 3-month period, comparatively speaking, two different time periods, and reduced our waiting period from 6 days to 2. And for 50 cases, that was our block of N that we wanted to compare, and reduced it from less than 50% actually going through the process and to admission, to only 1 person not going through the process to admission. It ended up that we just followed the patient and eliminated those things that were barriers to getting a patient in quickly. It resulted in over $2,000 per week increase in fees.
So that's the advantage. That's a great example of what, when you work with NIATEX and do that, you heard his markers around what he was doing. 49 of 50 folks that they looked at engaged in treatment when they went to open access, as opposed to 50% in the old system.
Correct.
Okay, so a substantial reduction in that, as well as a $2,000 increase per week in revenue from kept appointments and the lack of no-shows in terms of moving to a model like this. So you've got a lot of experts here in the room that raised their hands. One more time, those of you who've done this, if you could just raise your hand so people who might be interested can talk with you, that would be great. So if you're thinking about this, go ahead and talk with those folks across the place. So the other piece that's pretty interesting here is talking about email and telephone consultations offered. I read the USA Today now, and actually there was just an article around some woman who had a respiratory infection who went to some online doctor, called the doctor down in Texas and was prescribed antibiotics and was out the door with doing that. So the use of technology is incredible moving forward. I know this was an issue for us. We always thought that email was not secure, so we wouldn't allow clinicians to email back and forth because you can go in and change what people said and all those sorts of things. So I remember when I ran an agency, this was really difficult for us, but it's something that we need to be thinking about because people are now demanding it. So this access piece is critical to the work we're doing moving forward. The other piece on consultations, A lot of problems getting enough psychiatrists to do the work that we need, or addictionologists to do the work in substance abuse. We have models, and the folks that developed our curriculum for the doctors are experts in this consulting model. And we have one psychiatrist / addictionologist who works with a primary care clinic. And when people need support, they email him or they text him. And in 1 year, he did like 800 consultations to primary care physicians. Now he has another relationship, he sees them in person, but 800 of these consultations so that primary care doctors could prescribe antidepressants, medications for folks, medication-assisted treatment based on the consultation with the physician that was willing to do that. And it's pretty amazing when you sit with him, you know, his phone will go off and he'll have a text, and it'll, you know, be this communication that he has with the docs, and he sends it back, and the person gets treated immediately. So, incredible things happening with this. Patient engagement, I think this is where we're at our best. We have worked a long time trying to engage folks who have a chronic illness, a mental health or substance abuse problem in care. So I think this is a strength of ours, tailoring to the needs of each patient, moving away from programs to services, you know, so that we're not fitting square pegs into round holes, but having active and engaged folks in their treatment. This is really an area where I think when you talk with your primary care partners, that's the expertise that we bring. This engagement piece is something that they haven't worried about. You know, and when you work in primary care, the rate of patients that is seen ranges from 8 minutes to see a patient up to 15. So they're seeing somewhere between 6 to 8 people an hour, you know, 20, 25 a day in terms of their pace. And so you can imagine what the engagement is like with that. Now the problem we have is our engagement is hours long. So that's not going to work either. We can't spend hours engaging, but you just heard of a program that he's running through the NIATEX where the engagement happened through an open access and simply working more with the consumer. I assume you didn't spend hours engaging with them to get the 49 of 50 to remain in treatment after they got there, but it was simply responding when they were ready and reducing the barriers that we put up often in our clinical programs to keep people from getting there. So important to talk about patient engagement. Care coordination, and this is the definition of care coordination. We think, and we do a lot of these trainings when we talk about care management, and folks say, I'm already doing this. So when people say they're already doing it, I like this slide. It says, are you doing this? Not just referrals, not just referrals to the next step, but engagement, making sure they get there, making sure you get follow-up reports, making sure that they do that. That's care coordination. We had a lot of folks say, I'm already doing this. And what we know about referrals, and I did say this the last time I was here, but there may be some new folks here to hear this, is that particularly in mental health and substance abuse, if the primary care physician refers somebody and says, I really think you should see my colleague Joan King and be assessed for your substance abuse, 4 out of 5 people won't go see Joan. You know, only 1 out of 5 will actually schedule an appointment and go see her. Now, if I bring Joan into my office and I say, you know, I'm really concerned about your alcohol use and I'd like you to meet with my colleague Joan King and talk about that for just a few minutes, 4 out of 5 people will go for that appointment. But it's also true. Notice I said if I take the person down to see Joan, 4 out of 5 will go. Now, if Joan's sitting over here on this side of the room and I'm seeing you over here on the right side of the room and I say, please walk over to see Joan on the left side of the room, right. Not even going to do that. So even if you're co-located and in the same building and in the same floor, even on the same wing of a floor, you won't get people to go to the next appointment. And the same is true when people come in to see us and they're sick and we tell them they need to go and see their physician. They don't do that either. So it works both ways. And I think that's one of the learnings that we've had with our PBHCI grantee program is folks thought if we just brought the doctor into the space, people would come. It's not a field of dreams. If it was that easy, I wouldn't have a job helping people do this. But we have to be able to do this kind of care coordination, which is a much more active, much more engaged type of work with folks who are needing physical health help. Questions or comments so far? Okay, Dr. Olson mentioned this earlier today. I wanted to hop up. I have a problem with sitting still. Actually, I have a problem standing still, but the mic's here, so I can't, I'm stuck. This is a model that we use to talk about what we need to be doing as it relates to healthcare. And she talked about primary care physicians, and almost anybody in a physical health setting that works in primary care is going to know the Wagner chronic care model, the model for dealing with chronic illnesses. One of our problems with healthcare right now is we're an acute system. You know, we treat people in acute episodes, whether it's an acute episode of drinking or drug use or schizophrenia. We do a ton of things in the acute phase, and then once they move out of the acute phase, we don't do so well in following up on the chronic aspects of the issue that they have. So we use this tool a lot, and this has been really difficult because I can remember me having it drummed into my head when I was a clinician that as it relates to mental health and substance abuse, we don't use the word chronic because it's stigmatizing. Okay, so we moved to seriously and persistently mentally ill and things like that. Now that's not stigmatizing, not at all. So, but we moved away from the word chronic, and we've got to move back to it because that's the language that they use in the healthcare system. And you heard the comment today about to get into the healthcare system, and we are. We used to be out here in the community. We were one of the resources for people. What the Affordable Care Act and some of the most recent legislation has done is it's moved us into the healthcare delivery system. And I actually think that's where we want to be. I think one of the reasons that we've been able to be such easy targets for cuts and those sorts of things is that we're sitting out there all by ourselves. We don't have a loud advocacy voice. We don't have consumers and family members who have the same type of power that the AMA has and some of those other organizations. I actually think we'll do better if we partner and get into the healthcare system than if we remain outside of it. But that's just my personal philosophy, and I had that idea years ago, and it's worked successfully. So we're now part of it, but we've got to make sure that we don't lose all the years we've spent doing psychosocial rehab, treating people out in the community. But I think we can take everything that we've done for folks with mental health and addictions issues, and we can apply it to diabetes, we can apply it to heart disease, and we can move forward in terms of working with folks. So this is the Wagner chronic care model. And the other thing here, the self-management support, when I talk with folks about recovery, and I'm a huge proponent for recovery, I think it's key to everything we do in mental health and substance abuse. But when I talk with doctors about that, they think I'm talking about that room outside of surgery. And so the word that I've used in talking with primary care is this self-management support, because they're very up to date on that. And so I equate what we talk about in terms of our recovery principles as similar and the same as self-management support. It's helping people understand their disease, the issue that they have, and helping them take control of it and managing it day to day. So we can still have recovery. We don't have to give up recovery. We don't have to give up our language. We just need to be careful in our conversations that we talk about self-management support. And Dr. Olson, that gets to one of the questions that you asked. We also need to train our colleagues in primary care that mental health and substance abuse are chronic health problems. They are chronic health problems going forward. And so that's why we need to use the Wagner model. And then this, I guess I don't need to rush. I'm like, been rushing to all around, so I'm like, shh, let's get this out fast. So, I want to spend most of my time talking about the 4-quadrant model because I think it's something that's very familiar to all of us. This is Ken Minkoff and Chris Klein's work. And I hadn't heard this, but I was out in California, and they've actually taken Minkoff to be a verb, and you can be Minkoffed. So you're laughing, so a number of us have been Minkoffed, in terms of the systems change. We're actually working with Ken and Chris about taking the work that they did with mental health and substance abuse integration. We think that that work's all done, or needs to be done. Because as you notice here in the 4-quadrant model, the behavioral health risk and status, mental health and substance abuse has already gotten together and worked out our differences. And we're working very nicely together, right? Yeah, all right. That's what I like to hear. So this assumes that we do this, because when we go, this was our process in Ann Arbor, Michigan, when we did our first integrated clinic. I'd gone to a meeting for a year, and that we're good at that too. In behavioral health, if we want to make a change, we put together a steering committee. and we ask them to put together an action plan and a report with recommendations, and then we review it. And a year later, we haven't done anything, right? But we got a great report. So when I went to talk with our first clinic, I was involved in one of these year-long things that we were doing. And every meeting, and this was late at night, it'd be 8 o'clock, and this one health clinic in our community would say, I can't get anybody into services at the Washington Community Health Organization. So, not that I'm slow in responding, but about a year later I said, well, hey, would you like to be our first integrated healthcare clinic? It's like, hey, I can do something about this. So we actually took that and they became our first integrated healthcare clinic moving forward. But we talked like on a Thursday night. Thursday nights are big, good meeting nights. Don't know about you, but we have a lot of Thursday night meetings. So they were a good meeting night, and they talked with her, and she said, well, how about you send your staff over on Monday? I'm like, send our staff over on Monday? But that's the pace of primary care. That sounds really good. We'd love to have a community mental health center, substance abuse person over on our site. Send them over on Monday and let's get started. And we're like, whoa, we were thinking maybe 6 months from now. And she said, won't need you 6 months from now, need you on Monday. So we didn't go in on Monday, but we moved very quickly. In about 45 days, we created a whole program. And if you heard about raising the bar, that's a description of our experience there. We did on-the-job training, and we learned what we needed to do together as part of the partnership. And probably if we had done one of our planning processes and thought through everything that could go wrong, I wouldn't be speaking here because we never would have created an integrated health clinic. Because there's just a lot of things that people get afraid about. But this assumes that the work you're doing here in Maryland now with bringing mental health and substance abuse systems together is done. And so the people that you're taking into primary care have the capacity to see anyone that the doctor sends to them in terms of screening and making that first brief intervention. And then down along the bottom, obviously we've changed that to physical health. It used to be mental health and substance abuse. Chris and Ken are working with us on a new version of this. In fact, I have it in my briefcase upstairs that we're doing for primary care. And we're doing this very assumption that, everyone's been MNCOF'd, and we're now ready to take the MNCOF'd people and move into integration. So want to talk about, since we're all pretty familiar with this model, what this looks like in each quadrant. And I was also talking at the break, one of the things that we need to do, we've always focused on just a small segment of the population. The 4-quadrant model has us focusing on everybody, a public health approach to the work that we're doing. So we can't wait now until folks get identified and have a problem and bring them in. You've got to be working in a public health approach with everybody and expanding the work that we're doing. And I think the 4-quadrant model helps us do that, because when you look at quadrant 1, these are folks who have low behavioral health needs and low primary or physical health needs. Now, when you actually look at the number of people you're serving, you probably have nobody in this category. And so we talk about it as a 4-quadrant model where the boxes are of equal size. Just saw an article by somebody talking about the 4-quadrant model and saying we should have different size boxes. There are fewer people down in one, because there are very few people who have low physical health or low behavioral health processes, at least that we're seeing in the public system. But when we're doing that, what we need to be doing for that group of people is standard screening. So in a primary care setting, if we're partnering with them, we want to be doing screening for behavioral health issues. And you heard, and maybe, I'll talk more about this tomorrow, but SBIRT is a great place to start with this. SBIRT was designed to be done in primary care. And so this was a great place for those of us who work in the addiction fields to go in and help do these screenings. And then our problem is, except in a couple of really strong states like Wisconsin and Colorado, we really have SPI. Oh, no, that's the prevention one, SPE, SBI. Because what's happening is people are getting screened, but there's no referral to treatment. Right? That the RT part of this is really hard for people to actualize and to get going. And I think some of that is that we, and those of us who've worked in substance abuse agencies, they don't know about us. We haven't been out talking with them about the places that we can be and how we can be helpful. And so this is a place where I think integration would be great, is if we can get substance abuse agencies in the primary care site. The other thing I think these relationships are needed is that, I hate to say this, but I know you're all going to resonate with this, is that if we know the person who's calling us and asking to get somebody into treatment, they may get a different response than if it's a cold call and we don't know who they are. And I think if we're honest, we do that all the time. And so if we create preferred partnerships with our primary care folks, and they're people we know, or we have a staff there, and that staff calls and says, boy, Kathy came in today, she really needs to get into treatment today, we're much more likely to do that, because you know you're going to see me, you know, the next day, and I'm going to be screaming when you didn't take my person, than if it's a cold call from somebody. Then we say, well, on our waiting list, or we have an intake group in 3 weeks, you can come in then. So we need to be looking at how we can get these relationships going, but doing this screening. ESPERT's an example, the PHQ-9, the GAD for anxiety. We need to work with our primary care partners in getting them to screen for behavioral health issues. And what they'll tell you is they're not going to screen until they know they have some place to send folks. Because you don't want to create a liability. And if you know about it and don't do anything, you've created a liability. However, if you don't know about it, you don't have a liability. That's right. You what? Don't ask, don't tell. That's right. So, and that's what we found, particularly related to alcohol and drugs in our sites in Washtenaw County when we started. They were very okay about screening for health issues because, you know, the bulk of the antidepressants are already prescribed in primary care. They're prescribing the antipsychotics. But when we said, are you screening for substance abuse? They're like, oh no, we wouldn't do that. You know, we don't have anywhere to send them. We don't, you know, what would we do? And what we found is the minute that we had somebody there that could come in and talk with them in an expert type of way with a brief intervention, they were absolutely willing to screen. And the other piece is we weren't overwhelmed, because that's the other thing. It's like, oh my gosh, if we screen, we'll have all these referrals. That's not what the expert programs that are doing this universally are finding. You're finding some misuse, which can be treated in a short-term place, and then you're finding some abuse, which requires ongoing treatment. But you gotta have a place to send them. So the other piece, this is where we talk about an intervention being the addictionologist or the psychiatric consultation. You know, if somebody's coming in and needs a short-term option of being on medication, having the ability of not having them referred over and taking up slots is an important aspect of working with particularly quadrants 1 and 3, is having the capacity to meet that need immediately. Wasn't asked to speak about financing here today, but I left this on this presentation because somebody always asks, well, how do we pay for this? You know, how do we make sure that we can pay for this? A lot of places, these kinds of screenings can be paid for as part of the physical health visit. So you don't have to worry about that. They can just be part of the physical health visit. You have the expert codes that are already designed and available to be used in primary care for the screening and brief intervention. So there actually is a way to fund this right now. And if you don't know, the Center for Integrated Health Solutions has a web page. You saw that when Laura presented. If you go to that web page, you'll find an interim billing worksheet for the state of Maryland that will show you how to bill for all these things right now for integration. And we did that. It's interim because we're hoping for fundamental reform in 2014 to financing, but until we get there, people still need to know how to do this work. So these quadrant 1 folks, we need to be screening. And I should have on here, and I forgot to edit it, in our mental health and substance abuse programs, we need to be screening for physical health issues. It's part of a different presentation I'm doing here, but I have some of the information on the prevalence of physical health disorders in folks who have a substance abuse disorder. And then you already know that our folks with mental illness, and I will share this statistic with you, folks with serious and persistent mental illness who are on Medicaid can be expected to die at approximately the age of 53. Folks who have a co-occurring disorder, mental health and substance abuse, can be expected to live to about the age of 43. So we've got a huge health disparity here in the folks that we work with, and we've got to be doing something about that. That health disparity is equivalent to the age of death in sub-Saharan Africa. The 53 is equivalent to the age of death of people in sub-Saharan Africa, where there's a huge HIV outbreak. Here in our country, they're going to die because of the presence of an alcohol, drug, or behavioral health problem moving forward. So we've got to do something about this. I like to say, you know, people are dying while we try to figure out if we can do something to help them. So we've got to do this. Quadrant 2 are folks who have high behavioral health needs, high substance abuse use, high mental health needs, maybe both. And there I have the interventions broken down into people getting the care at the place they are most comfortable. You know, right now we separate them. We send this group of folks, we send them, they cut their head off and send it over to one of our behavioral health centers, and we leave their physical health in the primary care. What we're suggesting is that we do bi-directional integration, and that's what our grantees are doing, that they can bring primary care into the mental health and substance abuse organizations. And we had a great opportunity at our conference back in April to bring together 11 addiction specialty providers who have started to provide primary care. And we'll be issuing, hopefully quite shortly, a report about what the health home looks like when it's in an addiction specialty program. And so I'm pretty excited about that. But bringing a nurse practitioner or a physician's or assistant or a doctor into the mental health or substance abuse program where the folks are comfortable coming. Now, if they're comfortable going to primary care, then we take our services there. But the idea is that you can treat the whole person at the place that the individual is the most comfortable getting their care. So what you see there is there are a set of behavioral health interventions that can be done in primary care. A lot of primary care centers are doing medication-assisted treatment now. What we're finding in the folks that we're working with is that those folks getting medication-assisted treatment in primary care aren't getting the psychosocial supports. So we've got to work on getting the psychosocial supports into folks. And what we're finding in a lot of our addiction programs is people are getting great psychosocial approaches and supports, but they're not getting the medication. So if we put the two together, we'll have options and a continuum for everybody. But behavioral health interventions, there's the impact model for depression. You've probably already heard about that, but it actually has better outcomes for people of color than it does for others, which is kind of interesting. It has been found, actually the studies that Jurgen has done on that, Hispanic population seem to respond the best to impact. So that's kind of cool to know. There's the MacArthur Foundation model of care management and psychiatric consultation. You have the Strassel model of behavioral health consultation. That model posits the use of a PhD psychologist, which in some areas isn't possible because we don't have them. But they do nothing but short-term solution-focused therapy sessions when people come into primary care. There are no follow-up counseling sessions. You're seeing the next time you come into primary care for a short-term solution-focused session. So that's a really defined model that seems to be working. Moving our case managers into primary care, critical. To be able to do that, you saw that now funded under the new state plan amendments. Psychiatric consultation, we've already talked about that. You know, Laura mentioned this, this isn't for all psychiatrists or doctors. Our first psychiatrist hated this consultation model in primary care. He wanted to treat people with schizophrenia. And he said, you know, I thought I'd like this, I don't, can you move me? So we took our guy who liked working with homeless people and put him in, and he's been wonderful. Dr. Florence has done great at this. So this isn't for everybody. We've got to train. We have information on the characteristics of staff that make the best staff in these settings, but we've got to be getting this service out to folks. We also think that there are a group of folks who are going to be more comfortable coming to us than going to primary care, and so we need to have primary care staff in our programs so that they can see folks when they come in. To be honest with you, I don't know how many nurses we have in the audience, but we've actually found this model seems to align more strongly with nurses than it does with doctors. Some of that has to do with their training. You know, nurses are taught to be part of a team. Doctors are taught that they are the team. And I mean that in the nicest way. I mean, but they're taught from day one that they are the head of the team. You know, and they make the decisions and everybody else, you know, goes along with them. So you have to do some education working with the doctors of, yeah, you are the ultimate one. You're the one who's ultimately in charge, but you can be ultimately in charge and still be part of a team. And let us help you with that. But it's a fundamental thing that's bred into them from the day they start their training in med school. And so we got to help them untrain on that. And then you see financing. This is where the state plan amendments are going to be critical to help folks do this. The 8 quarters. Yeah, 8 quarters, 2 years. You know, I'm a social worker, I'm not good at math. So, but you can do that. There already is a 2004 state Medicaid director's letter that allowed states to begin paying for care management for folks with mental health and substance abuse problems back in 2004. You don't need a waiver. You don't need any of those things. You just need to do it in accordance with this amendment, and if anyone's interested in that, I'm happy to share it. We did that in Michigan before I left Washtenaw County, and it was very successful. We had told the state if they would submit it, and we could get the 50% federal reimbursement, that we would come up with the local match. And when the state saw our outcomes, even in Michigan where we have zero money, the state said, we'll pay the match because of the outcomes and what you'll save us in tertiary care by doing this disease management with the folks that you serve. So this was a couple $1 million that came to the mental health center to do disease management and managing our folks who had diabetes and heart disease and other chronic conditions. So that can happen today without an amendment, but the state plan amendment and the planning grant can also help you with those services. The other piece, and I haven't talked about this much, but I want to talk a little bit about partnering with the Federally Qualified Health Center. And there's somebody here, I don't know if he's here today, that always asks me about working cross-state. Are you here today? There he is, hi. I still don't have an answer, okay?
I won't ask.
You won't ask. So I just, you remember the weirdest things when you come to places. Like when I walk in here, I've been in this hotel, but I couldn't remember for what. And then when I came in this room, it's like, oh, there's that guy that always asks about cross-state billing when I come to Maryland, and I still don't have an answer for him. But partnering with Federally Qualified Health Centers, Federally Qualified Health Centers get paid in a different way than we do in mental health and substance abuse. They get paid per encounter, and it's a pretty good rate per encounter. It's going to be somewhere between $80 to $145 per encounter. And it's whether that encounter is 10 minutes or 10 hours. So if we partner with them, and this again varies by state, some states use the same rate. So you might get $145 if the doc sees the person and if the behavioral health person sees the person. Or you might only get $80 for behavioral health and $125 for the doc. So it depends on your state. You're going to answer that question for Maryland for me? Okay.
I work with Federally Qualified Health Care Center in Wacomico County.
Yeah.
And we have to see a person for 20 minutes.
You have to see a person for 20 minutes to get paid?
Before we get paid.
In the FQHC?
Yeah. And the rate is $2. Okay, well, that part's wrong.
I was going to say, I'm like, well, that's not what our billing worksheet says.
You have to see them for 20 minutes now.
Okay. So that's different. Again, you can have some unique things that have been put in by the state or put in by local FQHCs to do that. But a lot of places where I work, you can see them for 10 minutes. And we actually recommend the behavioral health intervention in primary care is 10 to 15 minutes. So you're just slightly over, so we need to talk. But it's a short-term solution-focused session done like Scott Miller and some of those folks say, talking about strengths. And I actually have someone that I just talked with on email that they literally have broken those 12 to 13 minutes down into 2 minutes for this, 3 minutes for that. And so when they train the staff in primary care, that's what they talk about. So, but FQHCs can bill for mental health and substance abuse treatment. Here in Maryland, there's sometimes issues with billing 2 services in one day, but I think you can bill 2 services in one day here in Maryland. You may be able to legally. It's what I've learned in doing this financing work is that states will say, sure they can, we may not pay them, but they can. And so we bumped into that a lot of places. I actually did a worksheet and we send them out to the states, and there was a Midwestern state that we found you could bill 2 services in one day, and we sent the sheet to the Medicaid director and we said, gosh, you've been telling people you can't, but we've read your Medicaid manual. And it says that you can, and they're like, well, sure you can, but we don't want them to. And we're like, well, we're going to publish this worksheet that says your Medicaid rules and regulations allow them to do that. And they were like, thanks. So, but anyway, there is financing for this as you move forward in partnerships. Our quadrant 2 folks are folks who have big physical health problems, diabetes, heart disease, asthma, those sorts of things. And they need some behavioral health problems addressing those physical health issues. There are ways to pay for that, and it is a new outlet for business. I worked with a program in Arizona, that behavioral health program that worked with an FQHC. These codes were billable. They made $200,000 in a year working with the FQHC and doing groups for people who had diabetes and people who had heart disease and doing behavioral health work secondary to physical health diagnosis. So these are it's a new potential opportunity for you in terms of revenue producing, in terms of working with these folks. So how many of you know how many people in your organization have diabetes? Clients. Yeah, not staff. So we got, the FQHC knows you've got a registry. Are you in behavioral health? Yes. Okay. So we got 3 or 4 folks here that know that. It's critical. It's critical because folks are dying of diabetes and heart disease. And even though I talked about this a year ago, we still only have 3 or 4 folks who are looking at those folks who have diabetes and heart disease. Here's what we know. A lot of our grantees have done health fairs in mental health and substance abuse organizations. Almost every grantee that does a health fair, and that is you put out in your waiting room blood pressure, cholesterol, you know, those sorts of kinds of screening things which can be done. Almost every behavioral health organization that holds a health fair and tests blood pressure has 1 to 3 consumers that have to be sent immediately to the emergency room during the health fair. Their blood pressure is so high, their sugar level is so high, something's going on. So that's the kind of liability that's walking into your doors with physical health issues every day. That at least 1 person should probably be sent to the ER, that they're that sick with these illnesses. And so we've got to be looking at knowing who has heart disease, we've got to be looking at knowing who has diabetes, and providing care for them. Quadrant 4, these are who we are most familiar with. These are the folks who have a serious and persistent mental illness, a major alcohol problem, diabetes, 3, 4, and 5 comorbid conditions. So these are folks, these tend to be our older folks in the system that have been working with us, and these are probably the ones we know best. And then we have interventions in primary care, and then interventions in behavioral health. These are the ones that you really need to know about. The other key thing you need to know is not only who has diabetes, but who's at risk of it. We can now tell 10 years before someone develops diabetes whether or not they're going to develop it. There are lab tests that we can run that will tell us this information, and we're not doing it. And so these are part of the new standards that we're talking about for services. I think this is one of my next to last slides, and then I'll open it up for questions. I know I'm also the only thing standing between you and the reception, and some food, and some drink, and I don't know if Tracy's back in here, but a while ago, she was thinking maybe she needed something to drink. So we gotta make sure we get you out to do that. But you don't have to start from scratch. Now, this slide used to talk about clinical models for integration, but here's what we found with using the word models. When you use the word model, people always get worried about fidelity. And what we're finding is that you have a challenge just implementing this model because all healthcare is local. So we've actually started to use the word strategies. So these are both evidence-based and promising practices that you can Google or any one of your search engines that you can find for doing integrated healthcare. So you don't have to start from scratch, you don't have to develop it on your own. You can look these things up. If you go to our website that Laura showed you, see, I'm not in CIHS, but I still call it our website. So that'll be for a while. But different examples of ways to manage doing integration. And this is sort of our expertise, if you will, out of the National Council, is helping folks match what your community's needs are with the model that we think would work the best for the work that you have to do. So lots of models. And then consumer involvement. Laura talked about this. This can't happen without the engagement of recovery coaches and peer support specialists. They actually can do things in ways that we as clinicians never can. They can relate to people, they can talk about how they managed to get walking, they can talk about how they managed to establish a life in recovery in a way that we can't. And there are actually 2 evidence-based projects for this, HARP out of Stanford, and then the health and wellness screening that Peggy Schwarber did. And then the last one is the WHAM program that Laura talked with you about, that Larry Fricks put together for us in terms of moving forward. So I put this up there to show you that you don't have to make this up. There are models out there, there are ways to do this, there are key reports that you can read and say, I like this from the Hogg Foundation and this from the Maine Health Access Foundation, and put together your program that's going to work for your consumers and the staff in your area. So other key elements, and I think this is my last slide. Oh, no, 2 slides to go. You talked a little bit about this. In order to be successful, we pretty much know that you have to do this warm handoff stuff. That referrals and asking people to go a second place just doesn't seem to work. So if you're going to head down this line, you got to be thinking, and I know Jennifer's here, and I know I did some TA with them. Their FQHC's literally across the parking lot, but people were getting lost between the 2 doors. Now you can't, that's really hard to believe that that would happen, but it does. No, people are not, it's not hard to believe at all. You know, if there are cars in between there. So you've got to work out some way to do these warm handoffs, which means that one person's taking them literally to the next person and getting the services provided for them. We've talked about short-term solution-focused therapy. We can't just take our models and move them into primary care. You know, they're not gonna work. We know that. So we've got to be working on short-term interventions that can occur in an exam room. I remember when we started this model in Washtenaw, our clinician said, "You mean there's going to be an exam table in the room when I'm talking to someone?" It's like, yeah, we're not going to have them up on it, but you know, you don't have to sit on it, you know, and the story, you know, those things that go along with the exam table. I said they can be sitting in a chair, and this is what we found is when we gave clinicians, mental health and substance abuse group staff that did this for us offices, they reverted back to what they knew, which was taking the person back to their audit office and doing a 45 or 50-minute session. When we made them provide the short-term solution-focused intervention in the exam room, they didn't, maybe it was the exam table, but they moved to solution-focused short-term therapy and move forward with the folks. So when folks say, I go in and work with them and they say, we don't have any space to do this, those are the easiest sites to work with, because then they work it into their clinic flow and it works even better. Screening tools, we've talked about that. This is a huge issue for us in behavioral health. How many of you use an evidence-based screening tool to determine the diagnosis of the person that you serve? Our FQHC friends have raised their hands again, but almost nobody in mental health or substance abuse. We use the clinical interview, which usually is 60 to 90 minutes, up to 3 hours to make a determination. In primary care, they use the PHQ-9, which is a 9-question questionnaire, and if the person scores more than 15, they provide antidepressant medication. Imagine moderating a debate between psychiatrists and primary care doctors over that issue. I had the opportunity to do that, and the psychiatrists were just appalled. Well, that's a 90-minute interview for me, and you need to check this, this, and this. And the primary care docs were saying, no. You know, this is an evidence-based tool. It's found to be sensitive, and we can do this. You know, and so you have to worry about bipolar illness and some of those sorts of things. But the likelihood that they found in primary care is that doesn't happen just all that often. That it's mostly just depression. And we, you know, so that 9-tiered questionnaire was done while the person was in the waiting room. The doctor looks at it and says, I see you're depressed. Let's do some behavior activation, some problem solving. But if you're over 15, let's try an antidepressant. So not quite that, you know, there's more to it than that, but there's a fundamental difference in how we use these evidence-based tools, and we have to start using them in our specialty mental health and addiction programs. We have no way to communicate. We can't send a 3-page psychiatric assessment over to primary care. They need like a paragraph, if that, to know what's going on. Question?
Provider that provides services, that funds the specialty mental health system, doesn't it require you to do certain things that a primary care provider doesn't have to do, providing the services under primary care?
So the question is, doesn't the public mental health system require things that take longer than in primary care? Absolutely. We have paperwork requirements and a whole series of things that happen, but I think we'll see some of those start to go away. The question is, what is the value of some of that work? And it's being demonstrated that we maybe don't need all of that information as we're going forward. But you're absolutely right. Some of that's required and laid on us that we have to do, but we've got to be talking with state officials about that. So the last two issues, confidentiality. This is a huge one. It actually, from my perspective, is not an issue. 42 CFR, HIPAA, and state mental health codes do allow us to talk. Don't want to get into that too much, but if you go to the Center for Integrated Health Solutions website, you'll find several documents. There's one there from SAMHSA that talks about 42 CFR and HIPAA, and through a qualified service agreement, you're being able to share information across organizations. You'll find information about an organized healthcare delivery system. It's different from the QSA, but allows you to share information under HIPAA. And then you just work with your state laws. But confidentiality, in my mind, is an excuse for not doing this, not a real barrier. But that's a whole presentation. If you want to talk with me more about that, I'd be happy to do it. But it really does allow us to share. And if you haven't seen them, there are 2 new documents out of CSAT on 42 CFR clarifying how you can communicate with primary care. They're called frequently asked questions, and there's a part 1 and a part 2. And it will echo some of what I'm saying here today with you, that it is possible for substance abuse agencies to partner with primary care and share information, and it tells you how to do that. And then finally, documentation. Where do you document the services that you provide? I think you document it in the primary care record. We went through that in our state in Michigan, and if the state came in to look at our records, they simply went over to the primary care office and looked at the records there. And so we integrated the notes, because if we didn't integrate notes, the doctors wouldn't look at them. But if our notes were integrated, they would see them each and every day when they saw the patient, and they would be able to see what what was happening. So if you're interested in how to do documentation and integration, we have supports and ways to help you with that. There are also some integrated mental health, substance abuse, and primary care records out there that are electronic that you can get and use that make this even easier to do. So the last piece, this is sort of a diagram, or it isn't sort of, it is a diagram of what we're talking about in terms of the new design. So for adults with low and moderate and youth with low to high behavioral health risk, probably going to be seen in primary care. And we need to be there to provide their behavioral health services. Adults with moderate to high complexity are probably going to be seen in the public mental health system. Notice we're keeping the kids completely in the primary care system. It's really important. I don't know about you, but in Michigan, once folks got into the public mental health system as a kid, we had this problem of transitions. Like when they became 18, how do we transition them to the adult program? We stepped back and said, why are they transitioning to the adult program? What didn't we do when they were kids? Rather than making that transition earlier, we refocused our work in our children's program and said, we shouldn't have this transition. We should be doing something that helps prevent them from coming into the adult system. So kids are really seen in the primary care system in terms of helping them with their issues, and then adults with primary care in the behavioral health setting. Any questions, comments, thoughts? Going once? Going twice? Off the podium, no. We'll end then now, and you have a reception at 6 o'clock, and thank you very much for having me here.